welcoming you to our wellness webinar today. My name is Ann Grace, and I am the IWMF's Wellness Program Coordinator. And I'm very, very excited for today's guest, Dr. JOnas. He's a best-selling author, a physician, and an advocate for holistic healing. Dr. JOnas, it's quite a feather in our cap to have you here with this unique group. And unique in that many of those diagnosed with Waldenstrom's will live long lives. It's a marathon, not a sprint. And that's why I think this topic of whole person cancer care is so important, because who wants to think of themselves as a patient for decades? I'm really looking forward to hearing how this field has evolved and how it can empower this particular population. So just a reminder as we go through our session today to please stay muted till the end. Type any questions you have for Dr. JOnas into the chat. We'll funnel them to him at the end and we'll have some time to discuss at the very end. Special thank you to Shelley for being here and for Rick editing this program. So just a little more information about our guest. We have been wanting Dr. JOnas to speak to our group for a few years now, and luckily we seem to get his attention recently, and we've been going back and forth for months about this. You know, we planned this for a long time, so we're so excited for today. Dr. JOnas is, as I mentioned, widely published. He's a practicing family physician and a professor of medicine at Georgetown University and at Uniformed Services University of Health Sciences. He's also a retired lieutenant colonel in the Medical Corps of the United States Army. Dr. JOnas was the director of the Office of Alternative Medicine at the National Institutes of Health from 95 to 99 and led the World Health Organization's Collaborative Center for Traditional Medicine. Prior to that, he served as the Director of Medical Research Fellowship at the Walter Reed Army Institute of Research. And he now advises national and international organizations on ways to implement evidence-based healing practices into their medical system. He serves as the president of Healing Works Foundation, and his newest book, which we're so excited for, it came out last year, is Healing and Cancer, A Guide to Whole Person Care. And that's co-authored with Alyssa McManaman. Dr. JOnas, thank you for being here. I want to ask you one quick icebreaker question. What made you say yes to this opportunity to speak to our group?
Well, Anne, thank you for having me. Appreciate it. And it's great to be here. This is a unique audience in some ways and not unique in many other ways. So I think a lot of the comments that I'm going to make are about cancer in general, the wider world of cancer. But as I think I'll be able to illustrate to you, in many ways, the wider world of cancer is moving more and more towards what many of the folks that have macrostomes have been experiencing, which is living with a diagnosis over a long period of time, because the advances in cancer treatment are getting such that there are large numbers of individuals living with cancer. The unfortunate thing is that with all the fortunate thing is that all the new innovations that are coming out and the knowledge from our understanding of the biology of cancer, and that includes macrostromes, biology of that are providing a proliferation of options. And that's a double-edged sword, because we don't have complete knowledge about what all those options actually do. And it gets to be very individual. And the problem, of course, with cancer in general is that we're focusing on the cancer, and that often leads to a neglect of the person. And the person is living with the disease, not the other way around. And as you said, nobody wants to be a patient for decades, right? They want to live their life. And it's getting increasingly difficult for our system to deliver this kind of whole person care and healing. And I think your members probably know this as much or more than anybody in those areas. So I'll be very interested in the dialogue. And so we decided in our foundation about 2 years ago that we would, because of the gap of the care of the person within oncology, within cancer care, that we would start an initiative to try to, again, re-engage person-centered care and whole person care into the system, and really bolster the areas of supportive care, palliative care, integrative care, which is sort of a new kid on the block, and what does that mean for the care of the cancer patient in those areas. So that was the reason, when you reached out to us, I said yes, and thank you, Anne, for all of your great help and working with my staff to kind of set this up. So thank you very much. It's a great pleasure to be here and to talk to you all. I'm going to talk a little bit today about whole person cancer care, and I'm going to be talking about cancer in general, not Macrostrom's macroglobulinemia specifically, but I think as a chronic long-term type of cancer, you'll find many of these comments very appropriate in those areas. You've seen my bio. I won't go into that. I've had a long area of work in primary care. And actually, our work here at Healing Works Foundation and my previous work with Samueli Foundation and Institute was focused on integrative health and primary care and whole person care in primary care. But as I said, in the last 2 years, have really emphasized and brought in resources to focus on cancer for a variety of reasons. I have no conflicts. I'm fortunate to be funded by nonprofit organizations that have no commercial interests in those areas. So I have no commercial financial conflicts for anything you're going to hear from me. And the resources I'll show you at the end, which are all collected on our website at the Healing Works Foundation, are all free and available to anybody that wants to download them and use them. So what I'd like to do over the next 30 minutes or so is really to define whole person cancer care and illustrate its rationale and the science that underlies it. To summarize how bringing the person into their own care process as a partner, as part of the team, optimizes both the quality and the length of life, and to review some examples of whole person cancer care happening out there in oncology right now. There's some great ones. And introduce some practical, accessible tools that you and your cancer care team can use to make whole person care routine and regular. To do whole person care, you have to first know what a whole person is. And so I'm going to describe what a whole person is in our conception. And this is the model that I'm going to show you here is organized and now has been tested out in healthcare delivery itself and found to be very efficient, very useful in those areas. It's grounded in something you're all probably very familiar with, which is the Maslow's hierarchy of needs. It's about 70 years old since it was described by Abraham Maslow. And basically, it is held the test of time. And what he had is this hierarchy in which every human being had basic needs such as safety and physiological needs, if you see that pyramid on the right, and then psychological needs, including belonging, love, and self-esteem needs. And then his model focused then at the top of the hierarchy on something called self-actualization, or achieving one's full potential. And what many people don't know is that before he died, he actually revised this top aspect, and he added an additional thing on the top, which he called self-transcendence, which went beyond personal actualization. That was the idea of transcending suffering through experiencing connection, unity, and even spiritual awakening. And so we see this basic set of needs that every human being needs to flourish, from the basic physical needs at the bottom through the psychological up to the spiritual needs in those areas. And I think that this, again, is the model we've taken as sort of the grounding of what whole person is and what their needs are. Now, we know in the last 70 years, a couple factors that have come in to play that require this be modified a little bit. Number one, we know that it is not a hierarchy. In fact, there are a number of people that don't even have the basic needs, but they're very strong in social, psychological, and even spiritual components. And they're able to have resilience and transcend things even without the basic needs. And we also know many people that have more than what they need in the basic area. And somehow they have very unfulfilled lives. They're lost and wandering because they have not actually filled in or attended to the self-actualization or the self-transcendence needs at the top, or they do not have the psychological belongingness and connectedness in the social environment in those areas. And so it's not a hierarchy, it's a circle. And in the middle there, we've reorganized this. So we would show what a person might actually look like. If at the center of who they are were the spiritual and mental components, and then the layer of other dimensions of the person after that, the social and emotional aspects. You don't have to have mental health issue to have a social and emotional body. Behavior and lifestyle, we now know, are extremely important. It's not just having food, but there's certain types of food that are better than other types of food. So we now have more specifics about some of those basic needs. And then, of course, the body and the external environment that they live in are the dimensions that are easiest to pay attention to, and the ones that medicine mostly pays attention to in those areas when they go about providing health care. But if they neglect any of these other dimensions that make up the person, then we see it creates challenges and obstacles to full flourishing and health. And in fact, can generate, in many cases, suffering if we have not paid attention to what a human being actually is. So let's take that as a model of what a whole person is. And if we do that, then it's fairly easy then to say, okay, well, then how do you provide whole person care? I've put it into these 3 steps, which people out in the clinical environment have found basically extremely useful in terms of doing this. It starts by what we call person-centered care and asking the questions and having a dialogue about what matters most to the person that we're providing the care. Yeah, and it's interesting. That involves questions like, what supports joy and meaning in your life? Why do you even want to have health care? Why would you engage in health in those areas? And for some patients, that's a little bit of a strange question coming from a clinician. But it is the thing that drives people to do what they do when they get up in the morning, right? What's important to you? And so grounding in that is the person-centered care. Number 2, it needs to be holistic. And I've just described to you the dimensions of a whole human being. And that means don't neglect any of them. You see them again in the model on the right there, the body and the external, the behavior and lifestyle, social and emotional aspects, and spiritual and mental. That means in your interactions with your healthcare team, make sure these are being discussed. They're asking you about these. You're exploring them and identifying that none of these have been neglected. And then finally, the third part is that it is a salutogenic orientation. Let me explain what that means. It means the things that produce health. I'll show that in just a minute. And it means asking, what are the personal determinants of health for this particular individual? What's being neglected, or what might facilitate their own inherent healing capacity? And that's different than treating the disease. Okay, the disease is the pathogenesis. That's the textbook I studied about in medical school. And pathogenesis was the study of pathos, disease, and genesis, the creation of disease. And that's what we focus on mostly in medicine. But in parallel with that is salutogenesis, which is what generates health. And this is where the behavioral integrative healthcare and integration is essential. And how do we facilitate that process? So this is what whole person care focuses on in order to rebalance our approach to health in those areas. Now, here's a model of what happens to most people when they hear the word cancer related to them. It sort of subsumes their entire life. And perhaps in Waldenstrom's, it's a little bit less intense than this graph is showing, but most people are just bopping along, and these are, the things that are picking up their attention, they're paying attention to and doing in their own life. And then suddenly they hear you have cancer, and boom, it sucks up 90% of their ideas, their consciousness, their energy, their activity in those areas. So it's a life changer. It's like a bomb in many ways for most people, because they say, how could I have that? I was feeling healthy, and suddenly you're telling me I have cancer in those areas. And I know in macrostroms, it's discovered often incidentally on a blood test or something like that. And suddenly they say, well, why is this happening? When that happens, the person is thrust into the oncology world. And that oncology world has a lot of resources, a lot of power, and they are focused on the disease. So that means labs, scans, surgery, chemo, radiation, and tracking things such as the tumor response, the treatment plan, clinical trial eligibility. And it's all done through a tool that many of you probably know and use every day. It's called the SOAP note, documenting the dialogue that goes on in the clinic. And that stands for Subjective Objective Assessment and Plan. And that's how medical records are organized around those SOAP notes that your clinician needs to write every time they see you. What that tends to do, however, it tends to take those personal aspects that I showed you before the cancer diagnosis and the individuals that are over on the left-hand side, the patient team, family, friends, work, childcare, energy level, body image, all those types of things tend to take a back burner to the disease itself. And medicine then focuses on the disease and tends not to pay attention to the patient. I'll show you a tool in a minute that you can use that we've developed called the HOPE note, Healing-Oriented Practices and Environments note, which actually provides the ability to ask those questions and have the dialogue about those core components of healing that I just talked about that are made up of the person in those areas. Here's an example. I want to use this and ground this in an actual case example. I'll call her Jan. It's not her name, but it's a real case. She didn't have a Waldenstrom's. She had, as you'll see, multiple other cancers, and she lived a long time with multiple cancers. So that had some similarities to Waldenstrom's. She got her first cancer, breast cancer, at 34 years old. She had young children, busy career. And then over the next 30 years, she was faced with 7 more different types of cancers in those areas. All of which were, some of which were very serious types of cancers and some of which were not. And so, she was living with this over that period of time. Now, if you looked at her medical record over that period of time and all the SOAP notes that were written, what you would see is this type of thing. Her initial breast cancer, her then melanoma and skin cancers, and you can see the treatments that occurred over there. A secondary breast cancer, probably induced by the radiation for her first breast cancer. 30 or 25 years later, then she got ovarian cancer. They figured out she had a genetic issue that increased, that was the reason she got many of these cancers in those areas. She had lots of treatments in those areas. And then when those treatments stopped working, she went into clinical trials and tried out various types of immune therapy, which is sort of the soup du jour in cancer in those areas. So if you looked at her record, her medical record, this is what you would see. What you would not see is that you would not see a lot documented about the impact of all this on Jen as a person. And here's a few of the things that you often would not see in her medical record. The tremendous fear and the lack of time that her diagnosis took up, her loss of hair and the nausea and the fatigue that occurred with the treatment and the cancer, the fact that she quit her job that was important to her, the development of neuropathy, depression. She gained weight after the initial chemotherapy, even though she wasn't menopausal at the time, but nobody addressed that in those areas and probably contributed to increased risk of the other cancers that came later. Insomnia, loss of libido, cancer denial. She didn't want to be a cancer patient that lived with a chronic disease for a long time, so she pretended she didn't have it. That allowed her to live her life, but it caused some other problems. many regrets and worries about I should have done this, I should have done that, guilt. And then as she got in towards the area where the standard treatments were not effective or not clear, a lot of confusion, because as she sought out, opinions, she got lots of opinions. And so having lots of options was great, but it was also not so great because everybody would tell you something different, and it was hard to make some decisions in those areas. This type of experience is actually becoming much more common. And the reason is good, actually. It's because overall cancer mortality since the time of Jan's diagnosis has dropped by over 30%, averting significant number of deaths, millions of deaths. And people are also aging, which means there's more incidence of cancer. It's growing. And the number of cancer survivors is projected to grow by 26 million to 4040, and that'll be over 7.9 or almost 8 million cancer survivors per year in those areas. So there are many people living with cancer as a chronic disease. Now, those of you with Waldenstrom's could say, hey, that's what I do every day, right? That's what happens to me. And that is true. And living with that chronic disease doesn't make you immune to some of the experiences or issues that Jan had to face, including anxiety that occurs from frequent testing and wondering what's going on in those areas, the need for a support system that can help you navigate the medical area. Side effects from the various treatments and the desire to avoid things like secondary malignancies that Jan had actually from one of her treatments, things like fatigue, anemia, peripheral neuropathy, and the desire to have targeted therapies, which in Waldenstrom's there is a growing number of. In the case of Jan and her ovarian cancer, there wasn't a whole lot of. The fact that there are associations with other aspects of one's health, such as immune conditions, even hay fever, smoking, occupation, etc., all of which contribute to the risk of Waldenstrom's. And the need to individualize and personalize, because there's no single treatment that's best for everybody in those areas. So you have to meet the person where they are and learn, again, what matters to them, which is the definition of whole person care. The drop in cancer mortality, we now know, is actually has not a lot to do with the actual cancer treatments. Here's an analysis of almost 20 years of FDA-approved drugs for cancer. And if you look at the overall gain in survival from all those FDA drugs, 124 different approved drugs, the overall survival on average is only about 2.8 months that has occurred from that. And that is along with a lot of the adverse effects that are produced. And you can see some of them listed over on the left-hand side in those areas. So having lots of options doesn't necessarily mean they're good options in those particular areas. And in Waldenstrom's, we have a huge growth with major progress in recent years, triggered by increasing detail of the biology of the disease and multiple treatment options in those areas, with a lot of it focused on targeted therapy and immunotherapy in those areas. However, this presents, as with Jan, major clinical challenges in terms of what's best for who and when in those areas. So very similar to other people who have cancer in these areas. It's growing. So why is cancer dropping? Well, the major reason that cancer mortality is dropping has to do with the prevention of those areas. And we now know that overall that 42% or more of cancers are preventable. One of the biggest factors is smoking, and one of the reasons that cancer has dropped is because, at least in the United States, smoking has dropped significantly over what it used to be. However, obesity is the second biggest lifestyle factor, and it has grown significantly during that time. And you saw over Jan's journey that she never smoked, but she had obesity, which was never addressed in those areas. And so behavior and lifestyle are important in terms of prevention, and they're also important in living with cancer. If you remove smoking, at least 18% of all cancers are related to excess body weight, physical inactivity, alcohol consumption, poor nutrition, basic lifestyle components. And if you add to that early detection and screening, this is the major contribution to why cancer mortality has dropped. The biology of cancer, including macrostroms, has changed significantly. We used to think cancer was just a rogue cell. It just escaped its control over its multiplication components and started growing. But we now know it's a lot more complicated than that, that it's not just the tumor, but it's also the environment in which the tumor grows, that there's this dance between the body and the tumor that includes the metabolism of the person, the immunity, the inflammation, even their microbiome now that influences what that dance looks like and whether the tumor progresses. These are called the hallmarks of cancer, have been well published over many years. They're added to every few years in those areas, and they have to do with the environment or the tumor environment. Here, for example, is one of those. That's the inflammatory part of the tumor environment. There are multiple aspects, both of therapy and the disease itself, that increase inflammation, which alters what happens to the tumor and its environment. And so the microenvironment of the tumor is influenced by the macroenvironment. Here, for example, is an article published in Nature several years ago that shows that this is not just about cancer. In fact, chronic systemic inflammation, much of it developed by environmental factors and lifestyle factors, leads to the underlying cause of many, many chronic diseases. So not just cancer, but depression, cardiovascular disease, neurodegenerative disease, metabolic syndrome, diabetes, and obesity in those areas. And so paying attention to this biology, to this environment, the wellness environment now has a solid scientific basis for what should happen. What are those components? Well, the ones that we have control over that alter inflammation, immunity, metabolism, the microbiome, many of these hallmarks are the basic things of wellness that you all have been talking about. What is your activity level? What is your diet like? How much sleep do you have? And what's your social environment like? And this all is gotten at by exploring what matters to the individual now in their life and facilitating their ability to get engaged in their own self-care in those areas. Here's some examples of research besides the biology research, but clinical research that illustrates this. This is just a few selected examples. For example, a 10% increase in the amount of ultra-processed food in the diet is associated with greater than a 10% risk of cancer. Walking as little as 30 minutes a day lowers the risk of 7 different types of cancers and the risk of mortality, even if you have cancer in those areas. High levels of social support compared to low level social support, this is the love part, alters the mortality, the actual death rate by 25% for those that are in the higher social support level. And 60% of cancer patients experience disordered sleep, which we know has a huge impact on a variety of chronic illnesses and the immune system in those areas. And so the clinical evidence also supports the biological evidence that we need to pay attention to these core dimensions of wellness. Now, how do we do this in a way that engages the person to be active and have hope in their own self-care and doesn't turn into a blame game that doesn't say, well, you shouldn't eat that or you shouldn't have done that. This is the reason you have. I have many, many patients that have come with me and says, but I'm a vegetarian and I exercise and do yoga. How come I got breast cancer or whatever in those areas? And this is not a blame game. This is about engaging the patients. And so this is the creative part that has to be brought into the conversation to make this a positive component. Now, patients want this. Here's a set of surveys that we commissioned nationally looking at what types of whole person and integrative care are available in the United States and what are patients interested in. Left-hand side is what the patients said they were interested in. On the right-hand side were the services that were available in most hospital institutions. in those areas. And you can see if you, look at these: nutrition, exercise, mental health, massage therapy, meditation, spiritual services, etc. Almost all hospitals had many of these services available, and we're making many of them available. But very often the oncologist or the oncologist team weren't even aware that they were available, or hadn't built it into the treatment plan. They built the cancer treatment into it, but they hadn't built these types of services into the actual treatment plan. And so it became actually an issue of just organizing what resources already were there to actually make them available. Now, over Jan's whole journey, the 30 years, if you took the symptoms, the person part of what she was experiencing, there were many whole person approaches that actually have good evidence that could have been made available for her. For joint pain, for example, acupuncture and hypnosis. Neuropathy, actually, acupuncture also can help significantly in the prevention of that. Fatigue and insomnia, significant improvements through exercise, yoga, cognitive behavioral therapy. Depression, both drug and non-drug approaches. Nobody ever discussed her weight gain with her, and this was a nutritional issue and should have been done right at the beginning in her first survivorship visit. Loss of libido, there are sexual counseling and other approaches, and then finally dealing with the fear and hope through early palliative care with serious illness was very important and could have provided a more holistic approach and services in those areas. Now, at first, this may look daunting to teams that already have, a complex situation of dealing with chronic illness. But really, any clinician, as this quote says by my co-author, Alyssa McManaman, who's an oncologist within the Veterans Administration, at its core, whole person care is about seeing an individual beyond the disease or illness, learning about and partnering with them on what matters now. What matters now in this particular visit at this particular time? So, for example, if you ask that to Jan right now, and after 30 years of dealing with cancers, she would say, well, I really want to spend Fridays with my grandson, okay? He gets off early on Fridays. I like to hang out with him. We like to do things together. Don't schedule anything on Fridays, okay, in those areas. This came out from asking her the question of what matters now, okay, through the Hope Note, for example. And so bringing that into the treatment team, okay, bringing that question into the case conferences, into the personal health plan, making sure the navigators and the advocates and others on the team know about this and that they incorporate it into the process is key to what matters in Jan. Now, this is something that the leadership in oncology has espoused for many years. Here's both the past president as well as the current president of the American Society of Clinical Oncology. And as you can see from these quotes, they have emphasized the importance of whole person care. I'll just read Eric Weiner's quote here. Some oncologists harbor concerns that they don't have time to establish a partnership of each of their patients, and I understand the apprehension, but I believe we must form these partnerships if we want to provide the very best cancer care. And Lynn Schuchner, the current ASCO president, has emphasized how palliative care does that. And I'll say it can do that. However, it's not enough just to have palliative or supportive care. You also need to bring in the evidence that I've talked about, including in integrative care. So guidelines. So we like to follow guidelines. It's important to follow guidelines. It anchors them in good evidence in these areas. And so if you just go to the guidelines on whole person care, ASCO and the Society of Integrative Oncology, SIO, have come out recently with new guidelines that actually our foundation has helped to fund in pain management, in anxiety and depression, in fatigue, which I know are all symptoms faced by people with Waldenstrom's. And so we have guidelines looking at the evidence in those areas. These complement the guidelines that already exist for survivorship and palliative care that have been out for a while in those areas. Here, for example, are some of the recommendations from the guidelines on pain. Acupuncture was found to be very effective, especially for AI-related joint disease and breast cancer, but also they recommended be offered to many patients for general pain, from musculoskeletal pain to postoperative pain. Reflexology and acupuncture had less, massage had less evidence, but still they were safe, and they looked like they had some benefit in these areas. Anxiety and depression, I know, important area with Waldromstrom's. Mindfulness-based interventions have quality evidence in terms of the ability to help manage anxiety and depression in these areas. And so it should be part of what's offered to all patients in these areas. Yoga is an example of a mind-body intervention that combines it with the physical that also has some benefits. And then you'll see a list of many others that have less evidence at this point, but again are fairly safe and seem to have some benefit, including hypnosis for sleep, lavender oil, and other essential oils, etc. If you look at the guidelines on fatigue, an area that I know in Waldenstrom's is one of the major presenting symptoms in many cases. During treatment, exercise, CBT, mindfulness all have impact on fatigue. After treatment, yoga and acupuncture, and at the end of life, cognitive behavioral therapy and other treatments like corticosteroids can have benefit on fatigue. In palliative care, it is recommended and has been for years that palliative care be introduced to all patients within 8 weeks of the diagnosis of advanced cancer. I don't know how I'd love to hear how does that interact with Waldenstrom's. Is palliative care part of the discussion at the beginning, or do they wait until later on? Most of the time we wait, we get late palliative care in those areas, very often delivered through hospice, which of course has many restrictions towards the end of life in those areas. But palliative care lists involvement of the family caregivers, addressing things like fatigue, sleep, mood, nausea, etc., education, discussion of what matters, the goals of therapy, incorporation of the patient into medical decision-making, because when the evidence is clear, you have to give people choices and incorporate them into the decision-making process. Care coordination is a key area in all of cancer. Cost is a big issue. And as more options arise, many of them are not necessarily covered by health insurance, and so costs can be significant. 4 out of 10 people with cancer say their out-of-pocket expenses were much higher than they expected. And in fact, bankruptcy is often caused by medical costs that were unexpected in those areas. It also leads to increased health disparities. That is the difference between the haves and the have-nots. The haves usually can get some of the experimental therapies or the new therapies, and the have-nots often can't. And so this increases the gap in incurred out of costs. However, health disparities have many, many other factors, including cultural and religious bias, the lack of appropriately trained and experienced providers that can actually engage in populations that do not have access to these services. And very often they get their care in community-based centers, which may not have the expertise for the particular type of cancer that exists. Trust is at the core of engagement and equity in these areas, and this is addressed through what's called cultural competency. And this is recommended as a key skill that all clinicians be trained in, and having the ability to address things like the cultural and linguistic issues, having the humility to actually learn from the patient and appreciate their expertise in these areas, and have a reflection of the patient population so that it's a welcoming environment for the patient in those areas. Now, several years ago, we developed a set of tools to help facilitate this process in routine care. We call it the Hope Note Toolkit. I'll illustrate to you what some of those things are. We started with primary care because chronic disease and whole person care was the logical place to do that. There was great affiliation. And we did an entire learning collaborative of 16 centers around the country. They developed the tools, they applied them, they addressed many of the challenges, and then it was published in the Annals of Family Medicine and other journals on what those issues were. And then a CME course was developed with Tufts University to help, and this was made available free by our foundation to help people learn these particular skills. When we then moved into cancer care, we took those same tools and we put together a leadership group. And here is a selection of institutions where many of these leaders came from. The group ran for 2 years, and what they did is they took many of these whole person care tools that I've just illustrated to you, and they began to make sure that they were customized for cancer care in those areas. And so we have a whole series of resources that I'll show you in a minute, specifically vetted by oncology teams for providing cancer care. A lot of the learnings from this leadership team were published in ASCO. 20 and 23, 24 is another one coming in 25, which talked about what were the minimum requirements necessary for whole person care within an organization. You can see a list of some of those there, anchoring it in what matters. And bringing the patient into the discussion early on was key, making sure that complementary and integrative and wellness components were a part of that. And then addressing some of the organizational challenges that this brought up, getting the leadership involved, educating the patients about what we're doing, the resource availability, and then alignment of the teams in those areas. There's several case studies from these organizations when they began to make changes in their health delivery system to make this easier to address those challenges. Here's an example of them. These are all on our website. I'll just illustrate a couple that I think would be particularly important to Waldenstrom's. The University of Pennsylvania, for example, and Barrister Cancer Institute found that their survivorship clinic was actually not addressing the key issues of survivorship that were needed other than just screening for recurrence rates. And so they shifted their entire survivorship clinic and renamed it to Survivorship and Wellness Clinic. They enrolled in the CMN's Enhancing Oncology model, which provided resources for a lot of these areas. And they hired a primary care physician trained in integrative care that then actually helped lead and delivered that survivorship program. So that's an example of how they made changes to provide whole person care. Inova, a large center, Cancer Institute in Northern Virginia, near where I live, had a center called Life with Cancer that was started 25 years ago with a $1 million donation, but they built that. Jan was taken care of there, and she didn't even find out about it until about her third cancer in those areas, but it was right there available and free. So it was and it's now embedded in all care locations, and there's no cost. It's actually become part of the culture. They actually don't have to go out and raise money in order to provide the services. It's a part of what the hospital system provides. Now oncologists are getting better on, informed on that. For example, a partnership with a GI oncologist actually brought in the Hope Note discussion into the case conferences, not just focused only on the cancer itself, but what the person needs in the case conferences. Now, these and many, many other resources, as I mentioned, are free on the Healing Works website. Here's a link to many of those. As you'll see, there's multiple ones that you can peruse, and these are all free to download and use however you wish in those areas. So enjoy that. One of those I'd like to point out, especially for clinicians in the audience, but for patients, you can bring this to your clinicians and say, I'd like to do this. One of them is called the Personal Health Inventory. This is an adaptation of a whole person care questionnaire, a very simple 2-page one, only takes about 5 to 10 minutes for patients to fill out. It was adapted from the Veterans Administration and their whole health program, and it starts with what matters to the person. And then it goes through their wellness components. It asks them about their health and wellness and what are the top areas of need using the Hope Note template that's part of that. This has been digitized to make it easier to use. There's an organization that then offers this called the smartmeasure.com PHI digital collection. So it makes it easy for the patient to fill out, for the clinician to track in those areas, and they can bring it into the electronic medical record in those areas. The resources then to support this type of care are also available and were developed by this oncology network that I mentioned. Here's an example of a few of those: financial impact of cancer care, cancer and sexuality, cancer and spirituality, and many, many other pocket guides that are available that summarize the science, the licensing, the up and the downsides, and the delivery issues that patients need to know in those areas. These are becoming much more widely available than our site, with an agreement we have through the American Cancer Society, in which they're picking up these and other resources that we and others have developed from this leadership team. Here's a list of ones that they have started to pick up to put into their health communication and delivery centers, their call centers, their website, et cetera, in those areas. So these then become widely available to millions of individuals. If you go to our website, you'll see a set of resources and tools for primary care docs. You'll see a specific link to cancer care, where a lot of these tools have been translated to cancer care. And if you're a patient, there's a button there that will take you to another landing page that's specifically information to patient. We call it the How We Heal campaign, and many of the resources there are available that are patient-facing and patient-centered in those areas. So, for those of you listening to this, if you have an action item on Monday, let's talk about, depending upon where you are, both in your journey and in the cancer care component, there are a number of things that you can do. If you're a system leader, if you're leading a healthcare organization, then engage whole person care into your quality improvement program, your practice improvement program. Every major healthcare center and hospital has a quality improvement program. Make the focus of it whole person care, like some of the other examples that I showed you early. To make it more routine and regular. If you're a clinical team or a clinician, a simple thing that you can do is simply take the personal health inventory, the PHI, do it yourself, try it out in clinic, hand it to patients, or send them the electronic link, and then have a dialogue with them and see what aspects and how does that change the clinical treatment plan. If you're a person with cancer, tell your care team what you need. In those areas, take the personal health care inventory yourself, bring it to your cancer team, and ask what resources are available in those areas. If you're a caregiver, make sure you're an advocate, not just an advocator, a navigator in those areas, or a caregiver, but also an advocate, and apply the personal health inventory to yourself. These are general wellness components that can help caregivers with burnout and other things in those areas. So wherever you are in the cancer care network, there are ways you can advance whole person care. For those that have care teams that would like to learn more about this and get continuing education credit, we do have a free 5-hour course developed by Tufts University on whole person cancer care, available for clinicians, and you can get credit both if you're a physician or a nurse in those areas, towards your licensing and education in those areas. So go to that link and you can start that with your team. As mentioned earlier by Anne, my co-author, Dr. Lissa McManaman, and I wrote a book that tried to pull all of this together. It's called Healing a Cancer. It's available through any venue that you'd like. It's available to your favorite bookseller in those areas. It is not yet, but will come out in an audio form. There is a guide on our website for those that want to use it to help with, to enhance their own whole person care there. But this is really trying to collect all the information and more into a single guide in the area of whole person care. So that's all I have to say, and happy to have questions. Again, our website is Healing Works Foundation. Feel free to go there, and as I mentioned, all of that is available. So again, thank you, and happy to have a dialogue and a discussion around this area.
Thank you so much, Dr. Jonas. There's so much to think about. I'm so impressed by how you got through all of those slides. It was a lot of slides, and we had some questions about having access to those slides. We'll definitely have the recording available for this video in a couple days, and you'll be able to revisit this presentation. So a lot of information here, and I think a lot of us are wondering, we're all on board for this idea of whole person cancer care, But how do we tell our doctors about it? How do we advocate? And I'm glad that you had some good advice for that in your talk. It feels like a lot of work for a patient to have to hold this up again and again, but what about my psychological well-being? What about my emotional well-being? So, I'm just curious if you have any advice for, and maybe you're making these presentations to clinicians and to oncologists. I would really hope you are, but if you have any advice for this, how can I get whole person cancer care? How can I get my doctor to pay attention to this
Mhm.
subject? What it would be, the first entry point for that discussion to take place?
Well, I think I've given you a couple examples of how that's happened, and there has to be leadership. Obviously, if you're probably many of you get your care within an academic health center or a large center because it's not a common disease. You probably have to go to a specialist that works in one of those areas. And very often the resources that I just mentioned are available in those centers. And it's simply a matter of coordination. Now, one of the things that you can tell the oncologist does need to be on board as a leader in those areas. They have to actually bless the process and say this is important. So first of all, they have to believe that it's important. If you don't have an oncologist or an oncology team that thinks that paying attention to these other things is important, sorry about that, but that's not the one that's going to actually do it. They actually have to believe it. So the leadership is very important. Now, that doesn't mean the oncologist has to do it all. Okay. In fact, most of these places, the oncologist says, yes, this is important. They just made sure that their delivery care system brought in those kinds of resources and made it available, and they train their teams on how to do it. And this is how the quality care. Once they got the system down to do it, it streamlined it, and they were able to actually do it within their routine care. Alyssa McManaman, for example, works in the VA, and she was able to bring in the Hope Note and the PHI and do it routinely in her regular care, and then tap into some of the resources she had available at her VA hospital in those areas or in the community. We've worked with a number of organizations that are safety net hospitals where there are no resources available, and yet they have organized, because of the quality improvement programs, relationships in the community to provide access to many of these kinds of resources. The Life with Cancer Center, for example, has partnerships all over the region that then make the care type available. So there has to be leadership in those areas. The costs are often a secondary question. Say, how do I cover the costs in those areas? And that is a challenge. As I mentioned, the Life with Cancer Center started off having to get grants in those areas, and then now has it built into their culture, and it's just built in routinely. So I'm looking frozen. Can you still hear me?
I can hear you, and you're not frozen for me.
Okay, great. Because on my side I'm frozen, but as long as I'm doing okay on your side, that's all that matters right now. So these are ways to do it. I think the thing that most oncologists want to know is that, is this something that's fairly easy to do? And we've organized it about as easy as possible. Okay, there's a set of tools. The last chapter in the book that Dr. McMahon and I wrote is really about how to do it within a healthcare system. How do you set it up and do a standard improvement component? We have a guide to read the book and to deliver it in those areas. How to identify and measure it in those areas. So we've made it about as simple as possible. And so if the organization says, "Oh, I can't do it," it's not an issue of not being able to do it, really. Okay, it's an issue then of competing areas, and that requires advocacy, and that's where you all come in. You can say, we need this. Often these places have a panel or a patient advocacy committee. Bring it to them. Saying this is important for us to have available, and be persistent in your area, in the area, because it is available, it is being done, and there are many examples again on our website and other places where it's happening.
Thank you so much. We have some nice notes coming through on the chat. Um, let's see, Judith Kelly is sort of asking about what the most common vocabulary is in terms of speaking with her care team. We've got whole person cancer care, integrative, psychosocial needs, quality of life, and all of those. I know I've heard all of those across the board.
Amen.
So that's something to consider. And
Yeah.
I see that Brenda also raised her hand. So Brenda, did you have a direct question you wanted to come off mute and ask Dr. Jonas?
Yeah, hi. Thank you, Doctor, for joining us here with in the WM world. Really great presentation. Really enjoyed it, and I feel like it is um, so beneficial for a diagnosis like WM to have this perspective with our treating doctors. And I feel like in Seattle at the Ed Forum, which was last year's conference, that I did hear a lot about this from the oncologists and the treating doctors, because there's always the question of what's better for me. Should I take ibrutinib or zanubrutinib, which could be for the rest of my life? Or should I do a short-term bendamustine and Ritux? Is that better for me? Like, what are the chances? And it all depends on, personal preferences. So I feel like the doctors, the oncologists that were there did have this perspective, even if it wasn't exact, the way you've put it, but just to be like, what is best for the patient and what they want, what is important to them. For me, I don't want to take a pill the rest of my life. I'll go for the chemo, and other people, it's the exact opposite. So I just wanted to sort of bring that perspective that I feel like the WM doctors, because they see us for so long, I think there's a better chance of this becoming really integrated within their care. So thank you so much for presenting this.
Yeah. No, I think you're absolutely right. I think because of the reasons you said, probably this is being done better, even if you are not sure you've seen it. This is probably being done better in the WM world than it is in the general oncology world. Okay. Because, it is a long-term condition, and you see, clinicians and the clinician teams, for a long period of time. So the shared decision making, it's interesting. In medicine, we keep harping again, hearkening and saying you've got to use good evidence. You got to use good evidence, evidence-based medicine, and that is true. I'm a longtime scientist, many publications, teaching science and evidence to medical students all the time, and that is true. Yeah. In a rare disease like WM, and in many areas and stages of cancer in general, of other cancers too, the evidence is not there, or we don't know in those areas. And so making some of those decisions then becomes something that the patient has to decide within a vacuum. The clinician can say, well, we know a little bit about this, or we don't know that. And of course, they need to say when they don't know in those areas. And some clinicians are good at that and listening to the patients, and some clinicians are absolutely sure they found the answer. But I'd be careful about that in the face of lack of evidence. And in a rare disease like WM, the ignorance is, unfortunately, the gap is even wider because there isn't as much clinical research in these areas. And so the shared decision making is really important. And this is where you gotta, if the head isn't there, use the head, use evidence, use reason, etc. But then go to your gut, go to your heart, go to your gut and say, what fits for me? What matters for me? Is this helping with my life, or is it not helping with my life? And then incorporate that in the decision making. And hopefully, if you have a clinical team and a clinician and a doctor who's willing to work with you in partnership with that, wouldn't that be nice? I think all of medicine, especially in chronic disease, would do better if that's the way it was.
Absolutely.
Thank you for your question, Brenda, and your thoughts about our WM docs. Anyone else have a question they want to come off mute? Judith Kelly.
Yes, I'm curious. I feel very fortunate that I have doctors that do listen, and I think just listening is probably a big part of feeling empowered as a patient. So give them high marks for that. And I I do agree with you about this shared treatment. They seem to be very on board with talking about exchanging information to arrive at the right treatment. I don't see the wellness or whole patient care in there, though, yet. I think that's still very early stage. I see the interest and the acknowledgement that it's important. So but my doctor talks to thousands of patients a year. I talk to my doctor a few times a year. There's a big power imbalance on a lot of
You
levels
bet.
in terms of communication skills. He's highly structured and does it that many times, and he's a subject matter expert. I'm the patient, fewer interactions, and no structure for communication. Is there a starting point for us as patients to be better advocates on the wellness side, knowing that maybe 10% of what we say would ever get incorporated into their soap notes because it doesn't fit? That's not what they're being paid for. I understand that. There are statisticians and researchers, and they're judged differently, different metrics than wellness. So I don't know. Is there a fictional Jan that you've got that where you could give her the questions that she might have asked her doctor to get greater acknowledgement or push for an answer to her weight gain or her fatigue? Is there a model for us to learn how to even ask the questions, even if you're going to tell me at the end of this, yes, that's the good news, I can give you that model that will cover a lot of these wellness issues? You will probably get satisfaction about 10% of the time in terms of a response at this moment in time. But what's our starting point?
Yeah. No, I mean, that's you covered a lot of ground there, and that's a key issue. And I think the power imbalance, the time imbalance, the focus issue is there. Uh, you know, many of these wellness components that we've talked about, especially, I won't say that. I was going to say especially some of the lifestyle things. Those are the easier ones to talk about, right? Nutrition and exercise and sleep and stress issues. These are just basic core issues that all of medicine should be talking about, because they, as I illustrated with just one example from the science of inflammation, but there are multiple other scientific support to these areas. These are fundamentally the same almost with any chronic condition that you have, and they will keep you feeling better no matter what your diagnosis is. And so they should be a standard part of how healthcare is delivered. And that includes the psychosocial support, so the social and emotional body, that sort of next layer in those areas. And yet in medicine, we say, well, you got to have a mental health issue. You've got to have a diagnosis of depression or anxiety, and then I can give you something for it, okay, in those areas. But that is not true. In fact, there are many, many ways of addressing anxiety and depression, which are evidence-based and scientific-based. I showed you the guidelines on that in those areas. And, so it depends a little bit on what your, clinician's time is. If they're listening, hey, you're 80% there if you have somebody that's going to listen. And to re-emphasize that this is not something the oncologist then has to do. They have to bless it, and the team does it. So, for example, at Life with Cancer Center, the example I gave you at Inova, the GI oncologists who brought this into the case conference, he didn't give the hope note. He wanted to because he liked having the discussion with his patients in those areas, but he didn't have time for that. So guess what? Somebody else on his team did that, a social worker, a clinical nurse, et cetera, and then brought what mattered to the patient into the case conference in those areas. And so it didn't take the oncologist any more time than just saying, hey, listen, talk to this team member. She's going to ask you a couple questions in those areas, and we're going to incorporate what's important to you into the case conference. So again, utilize the team, okay, in those areas is key. And this is how this GI oncologist did this, and it didn't really take much time in those areas. I forget what the other issues were you had, but
I think it was the patient. If I'm Jan, as we're all Jan,
yeah,
and all of those things happen to me, how do I present them? The doctor is incredibly structured. is
You
given a
bet.
structured and does this over and over again. We get that one shot every 6 months
Yeah.
to talk about fatigue or weight gain. How do we do it in a way that the doctor is more inclined to say, I hear you, either I can't help you, go back to your primary care, or I think I can help you. But how do we ask the question in a way that will penetrate the veil?
Even a statement like "I hear you," go back to your primary care if you have a primary care doctor that is doing this. Okay, again, most even primary care docs aren't very well trained in nutrition, for example, so they're not going to actually know what to do in those areas. So you've got to find a team. And that team may be outside the oncology team in those areas. I think the other thing that was recommended by this cancer leadership group, because this was a real challenge, is that you really, the patient, you know how healthcare systems now have patient navigators. Okay, so we got navigators. They're hired by the system. They help you get through the system. They're really serving the healthcare system, right? Just helping them to helping you to actually get through the complexities of the system. You need, you should find a trusted advocate who is your navigator. Okay, so that you can sit down and talk about these areas. And when you go into the visits, they're there with them, and they're not you. Okay. And so, you're not, a lot of the dynamic of what's needed for the patient, if the doctor is not able to listen to you for whatever reason, okay, in those areas, the navigator can be there and can kind of be your assistant in kind of doing that. And preparing for those visits, through some of the resources I mentioned to you on the thing is component. Or if you have a long-term relationship with a doctor who's ready to listen, okay, buy him a book, give it to him and say, hey, this is the kind of care that I want. Okay, can we work towards this care? Okay, and I don't want this to burden you. You understand, the way they're trained, their structure, their resource limitations, et cetera, but I want to work with you to help in those areas. And how can I do this? Okay, so provide the open question in those areas. So.
Wonderful. Thank you so much. Phenomenal presentation.
Thanks for your question, Judith. I see, Brenda, you raised your hand again. Was there something you wanted to iterate?
Yeah, Doctor, you had a slide specifically kind of referring to peripheral neuropathy. And I know that's a big issue for a lot of people in the WM world. And it's also an issue where many of the doctors are like, sorry, we don't really have anything for you. But the integrated practices actually can help, I guess, manage. Can you go a little bit further into what you know about the peripheral neuropathy? And
yeah, no, peripheral neuropathy is a major issue with many people with cancer due to the treatment. And the guidelines that I showed you on pain, the ASCO and SIO guidelines, they do go through what does the evidence currently say about pain, including peripheral neuropathy. Now, there wasn't anything that rose right to the top that said, we know this works, okay? There are a few drugs that actually can help with it. There's some things like cold packs that do help some with it. What Jan did, and it is in the guidelines, but it's not at the top level of science because they haven't done large studies on that, but there are some that actually show this, is that acupuncture helps prevent the advancement of peripheral neuropathy if you're at risk for it. So if you've had multiple types of therapy, or maybe you have some mild peripheral neuropathy, but you're at risk for getting it worse, acupuncture and a certain type of acupuncture, which is published and in the guidelines, okay, can be delivered. So that was actually available in the Life with Cancer Center at Inova, where she was getting her care, and so she went in and actually saw an acupuncturist there. Now they only provided 6 treatments, and she needed more than that, so she ended up kind of paying for some additional treatments on top of that. But that was an example. They should know about the things that are out there on the internet. Okay, saying you can use this and use that. And there are some things that make it worse. For example, there are some supplements out there that were advocated by peripheral neuropathy, by companies, et cetera. And when they, in some of those, when they did the studies, they actually felt it made it worse. So your doctor should know about this, right? Your doctor should ask you about the supplements you're on, okay? 60 to 70% of cancer patients are taking some kind of supplement or visiting a practitioner and getting other types of treatments. And if they're not asking about it, then they're not actually able to have a dialogue with that. And sometimes those things can interfere with the other kinds of treatments in those areas. And so they need to ask their patients about that and know how to handle that. Memorial Sloan Kettering has a great free website for clinicians, for doctors, on supplement interactions with drugs, okay? So if you have your assistant say, here, check off the supplement that you're on, and then just check it on that website and see, are there any contraindications here? Should there be some things that they're on they shouldn't be on, or those in the areas? Those resources are available, and they're available free to doctors. It's a matter of saying, this is important to me, and I'm going to put it in priority. And they don't know it's important to you unless you tell them. Okay, they're not mind readers. They're very lineal in thinking. Some of them are intuitive. Many of them are not very intuitive in those areas. And so you've got to say, hey, this is important to me. I am taking this. Okay. And, if the medical record documents all your supplements, then you'll drive all the clinicians, especially the nurses, crazy, and the pharmacists crazy as they go through all your list in those areas. But hey, guess what? Now they're at least asking the question, right?
Yeah. Absolutely. Thank you so much.
Thanks.
I did want to mention a little something about the question on vocabulary, because I do think this is key. And as the concept of whole person care becomes fashionable and it becomes a good marketing tool, okay, we provide whole person care. You'll see hospitals now that they'll use it as a marketing tool. But when you dig down under what they actually provide, it's hollow. It's not actually there in those areas. The vocabulary, I think, is very important. The reason that we use whole person care is because we believe it solves the issue that many of these other terms have limitations for in those areas. So, for example, integrative care is usually meaning some kind of complementary alternative approach, much of which doesn't have a lot of evidence in those areas. And that's what a person, thinks about when they think of whole person. That is not completely whole person care. It's one aspect. There is some evidence for some of those areas and that kind of thing. Even palliative care, which is and supportive care, which is about as close as you can get to the concept of whole person care and is used routinely out in cancer care, is incomplete. Because a palliative care physician usually has a lot of drugs and procedures, but they don't necessarily have a lot of these other kind of components that are available, supportive care that are available. Those are siphoned off into something else, like the stress management, into psycho-oncology. And you have to have a diagnosis for those areas sometimes before it becomes paid for. So we created this term called whole person care and defined it the way that you've just seen in order to really get past a lot of these challenges. Palliative care also is usually only done towards the end of life. There's a marked shortage of palliative care physicians. They aren't necessarily trained in integrative oncology, as I mentioned, in those areas. So what the person wants, though, is they want to be cared for as a person. And these tools are really allowing you to go through that and fill in what kind of resource and support gaps you need from any of those other types of terms and components that are available and out there.
All right, friends. Does anybody have any other questions for Dr. Jonas before we take off, or anything else you'd like to share? You can type it into the chat, or you can raise your hand and come off mute. I see a lot of folks still here. A lot to think about, a lot to consider. So we'll have our recording of this available in a couple of days. And if you want to, certainly if you want to circle back and ask questions after you've had some time to let this wash over, wash over you, you'd be more than welcome to reach out directly to me, and I can funnel them to Dr. Jonas. I want to say a huge thank you to you. I see a couple other no, wonderful, lots of nice notes coming through. But I just want to say thank you so much, Dr. Jonas, for your time, for making the very valiant effort to pronounce Waldenstrom's, which is
Waldenstrom's macroglobulinemia. I know that's
getting there.
not difficult, at least for me.
Appreciate that.
I
Yeah.
did have I'm not an expert in this particular condition. I did have a patient though with it several years ago, and so learned a lot from them in terms of the management of those particular areas. I'll be happy to make the slides available in PDF form too if you want to send those out so people can look at those separately. I know that's always helpful. Went through them pretty quickly in those areas. So.
Thank you so much. I will be sure to include the PDF of those slides in our follow-up email. And I see that I maybe missed a question. Connie is raising her hand.
Yes, I had a couple questions. I know I asked my oncologist the other day if acupuncture is something that I can do if I have angioedema, and she did not know.
Yeah.
And it's not the angioedema like an allergic reaction. It's a C1 inhibitor deficiency problem.
Yeah. Yeah. So the question is, can you use acupuncture in that circumstance? And the answer is yes, if the acupuncturist is properly trained and has worked with patients with cancer and who are familiar with what they need to be careful about when they're treating a patient with angioedema. Okay. The side effects are very small, but they are existent. They are there from acupuncture. It's not a completely benign procedure. So, they need to be careful in terms of low platelet counts, for example, anemia, where they stick the needles, how deeply they do it, and that type of thing, the location of where it's done. And a good skilled acupuncturist will know, how to balance if they're Chinese acupuncturist or trained in energy acupuncture, they'll know where to stick to help with the psychosocial and some of the physiological shifts of acupuncture, without causing side effects or, getting it into the wrong spot in the body. Where it might cause infection or something like that. Obviously, it should be sterile needles and all disposable and all that kind of stuff. So on our guide for acupuncture in cancer, so there is the guidelines that I mentioned from ASCO and the SIO, but on our website, we have a pocket guide for acupuncture, which describes not only what we know about the evidence in those areas, but where the proper licensing and training organizations are in the country so that you can check with the acupuncturist to make sure they're properly trained in those areas. So, check those out first to make sure that, if you get acupuncture, it is by somebody that knows what they're doing.
My other question is, I've been thinking about in the last year or so, how can we find a primary care doctor that will join my team? Can I interview primary care doctors and say, this is what I'm looking for? I'm looking for someone, because a lot of times my oncologist will just say, well, go to your primary care about that. And, she doesn't really understand anything about Waldenstrom's and the angioedema part that I have, because it is even more rare to have Waldenstrom's with angioedema. And so it's I've been thinking about this, like, are there primary care doctors that are going to focus on being a part of a team with an oncologist? Are they training them now? Are they already out there? Those kinds of things.
Yes, there are. That's an excellent question. And you do have to put together, now, you do have to put together your own team that might involve primary care doctor that, provides this kind of care. If your oncology team can't in those areas. And that's fine as long as they're working, in tandem and closely together in those areas. And you are right, not all primary care doctors know anything about this, not just WM, but also may not know much about lifestyle and nutrition and all that, as we mentioned. I think probably one of the best, there are a number of organizations that train and license primary care clinicians, doctors, nurses, etc., in these areas, and you can look for that. I think the one that is most widely distributed internationally and has probably the most solid professional training is the American Society of Lifestyle Medicine. Okay. American Society of Lifestyle Medicine, and they train, license individuals. You can get a certificate in lifestyle medicine, which shows that you actually know how to do this, okay, in those areas. And many of the people that do that are primary care doctors, okay? And they have a section on cancer care also in those areas. They don't have one for WM. Maybe you want to start one with them, but they do in cancer care. And so if you go there, that's probably one of the best sites to first look for and identify on an international basis people that have had this additional training and brought it into their primary care.
All right, I think we have time for maybe one more question. Anybody want to chime in? Feel free to unmute and maybe just share your thoughts about something that stood out. Carol.
This is, you may or may not be able to answer this. I'm concerned about the ability to continue research in these areas, considering the administration's current approach to slashing funding for the National Health Institute. If you have any take on that. I was encouraged when you said most of your funding, I think, comes from private sources, so perhaps not so much from government funding, but I have concerns about that.
Well, I think we all have concerns about that. As you know, was at the National Institutes of Health.
I know.
And had this been coming down when I was there, I would have been pulling my hair out, in those areas, mainly because it's very unclear actually how it's going to pan out. And I think we're too early in the process to know what's going to happen. Hopefully, I'm an eternal optimist, and so I like to see that this might provide opportunities at some point that might open up the care in wellness areas, because the current administration says anyway that they're very interested in wellness and well-being and this type of thing. So that might provide opportunities. But if it isn't rationally and carefully shifted towards those areas without destroying what we have, because what we have is what's leading to all the advances that we've got in those areas, then we're in for a long ride. And I think it's just started in those areas. I think we haven't seen yet what RFK, who was confirmed as the HHS secretary, is actually going to do. The concept of reducing chronic disease is a great idea. There's ways to do it. There's good evidence on how to do it. We know how to do it. And so if they bolster and emphasize that in those areas, it could have positive effect. But if it's cut and burn and then see what survives, then I think we're going to have problems.
Thank you.
Thank you so much, Carol. And thank you, Dr. Jonas. I look forward to, seeing how all of this continues to evolve. And I want to thank you so much for your work and what you're doing to help further holistic healing. We have we've collected a lot of our own anecdotal evidence in this group who attend our wellness programming regularly and who say that it helps improve their quality of life. And I'd like to think their outcome as well.
You bet. An organization in a field like yours there's a huge strength in collecting that anecdotal evidence and organizing it. So if you get your scientists to start working with the network that you have around the country to actually systematically collect and document that evidence, that is, there's nothing better than that on the ground practical knowledge in those areas. So I hope that's something maybe your organization can do.
Oh gosh, yes, absolutely. And watch out.
I will.
Once I'm motivated for something, watch out.
Great.
So thank you everybody who's taking the time to be here today, and I hope to see all of you soon in other webinars. And Dr. Jonas, thank you again so much.
My pleasure. Thank you.